Okay, we will start by knocking on the patient's door before coming in. We will walk in, perform hand hygiene. We will then convey with our patient, hello, my name is Gus, I will be your student nurse today. We will be doing a head-to-toe assessment on you today. Do I have your permission to do so? Please and thank you. We will then check the patient's ID bracelet in their ankle, and we would do a two-step verification by asking the patient for their name, date of birth, that matches their ID bracelet. From there, you can also inspect that the patient's appearance matches their age, no signs of distress, behavior is normal, and facial symmetry is even. We will then ask the patient a few set of questions. Do you know the reason of why you're here today? Do you know today's date? Do you know who the President of the United States is? As well as, do you know the place you are in? Patient is orientated ×4 by place, time, situation, and place, time, situation, and I'll just move on from there. We can also assess if the patient's speech is clear and verbal. We will then see that the patient is well groomed. They just recently got out of the shower. They have good hygiene. We will start by doing a head inspection. We are looking for the shape of the head, which is round, as well as facial symmetry. We will then move into assessing the skin of the head. Skin of the head is clean, dry, and intact, matches ethnic background. Lips are pink and moist. We will then inspect the patient's scalp as well as their hair. Scalp and hair are clean, dry, and intact, no signs of dandruff. From here, we will also inspect the neck. The neck is symmetrical to the rest of the body. Shoulders are even. Both subtermal notch and trachea are midline. From here, we will then move to palpating the head. We are going to palpate the head for any signs of tenderness or masses, which there's none. We will then palpate the carotid artery one at a time for a little bit. Then we will move to the other side. We can assess the carotid pulses are +2, rhythm is normal. From here, we will then palpate the lymph nodes, starting with the preauricle, postauricle, occipital, tonsil, submandibular, submental, then going down to the pre-cervical, post-cervical, and the supraclavicular. From here, we will then have the patient perform active range of motion exercising, having the patient touch their shoulders side by side, performing flexion, hyperextension, as well as circumduction. And then we will have the patient push against the force of our hand one side and then do the same on the other side bilaterally. From there, we will then move on to inspecting the eyes. We can see that the eyebrows and eyelashes are clean and dry. Eyelids on both sides bilaterally are clean, dry, and intact. No clean, dry, and intact matches ethnic background. We will then pull the skin at the bottom of the eye to assess the conjunctiva. We will do the same to the other eye. Conjunctiva is pink and moist. We can see that the sclera of the eyes are white on both sides. And then we will then perform parallel on our patient. We will have our hand in the middle of their face. We will flash our pen light on one side, do the same to the other. We would do that to the other side as well. Then we will be performing EMOs, which is having our patient look at the tip of our pen light. We will be going up, back to the middle, down, back to the middle, to the left, back to the middle, to the right, back to the middle, Then we'll be going at an angle, starting at the upper left, back to the middle, lower right, back to the middle, upper right, back to the middle, lower left, back to the middle. Then we will still have them look at the tip of their pen light going towards their nose and out their nose. We can assess that the patient's pupils are reacting to light, pupils constricted to from a 4 to a 3, and that the eyes are well accommodated, no use of facial facial motion while doing so. From there, we will then inspect the nares. We are looking for the mucosa of the nares, which is pink and moist, no signs of patency, no signs of flaring, as well as septal deviation. We will then move on to the ears. We are looking for any lesions in the auricle, trapeus, and lobules. Skin conditions are clean, dry, and intact. Skin matches up in the background, no lesions bilaterally. We will also assess ear drainage on both sides, which there's none. Afterwards, we will then perform a conversation and whisper test. We will have the patient cover their opposite ear, keep the other ear open on our side. We will then back away a couple steps. We will then, by collecting baseline data, we will say a word in a low tone to the patient. Then the patient will relay that word back to us. And then we will then whisper a word to the patient. And then the patient will relay that word back to us. From the whisper test, we can assess that the patient can hear a conversation correctly, as well as listening to low tones of voice and relaying that word back to us as well. We will then move into the mouth by using our, oh boy, I have to open this up. By using our tongue depressor, we will have the patient open their mouth. We will put it right on top of their tongue, pull down. We will be checking the sublingual and buccal mucosa, which is pink and moist. The soft and hard palate are pink and moist. Uvula is midlined. Tonsils are symmetrical, pink, moist, no inflammation. We can also check that the patient's teeth are their own, no dentures, teeth are intact, no signs of decay or loss of teeth. We can also check that the patient's gums are pink and moist, no signs of bleeding. Okay. From there, we're gonna move down to the rest of the body, starting with the chest. We can see that the patient is a nose breather. From here, we are checking for any visible distension of accessory muscles, as well as retraction, which our patient doesn't show. We will then see that the patient's ease of breathing is through supine, prone, and upright. Afterwards, then we will then, let me see. Okay, we can then see that the patient's thoracic expansion we can check by cupping our hands here at the bottom. We will have the patient breathe in and out. We can see the thoracic expansion is symmetrical and depth is normal, but that's not the right position for this. Patient shows no signs of coughing or sputum. And after this, we will then come back to explain to the patient for JVD distension. For this, we will tell the patient that we will lay them down flat on the supine position, no pillow on their head. We will use our pen light to assess the side of their neck for any jugular vein distension. And we will do so to the other side. We will then raise the head of the bed up to 30 to 45 degrees and do the same thing, using our pen light to see any jugular vein distensions on both sides, which there's none. Afterwards, we will then see the patient's chest shape, which is 1 by 2, and the chest is symmetrical. From here, we will then palpate the chest. we are looking for signs of tenderness, masses, or crepitus. We would do this both anteriorly, posteriorly, and laterally. But for the mannequin, we're gonna do so anteriorly. We will then also palpate the 5 cardiac landmarks, starting at the right side of the sternum, second intercostal space for the aortic, moving to the left, second intercostal space for the pulmonic, left, third intercostal space for the herbs, fourth, left, fourth intercostal space for the tricuspid, and then fifth intercostal space midclavicular for the mitral. We are looking for signs of heaps and lips. From here, we will then palpate the patient's peripheral arteries. We already did the carotid, so we're gonna move down to the radial. We will do this bilaterally. Okay, then we'll do femoral pulse. Move down to the popliteal pulse. We will do so one at a time by bending the patient's knee. We will do so to the other side. Moving down to the posterior tibial, and then for the dorsal pedal. All pulses are +2 normal rhythm. We will then also palpate the arms with the upper and lower extremities for temperature. We would check that the skin is warm to the touch, as well as checking for capillary refill on both thumbs of the upper extremities. Capillary refill is less than 2 seconds, and we will do the same thing to the lower extremities for the toenails on the toes. Okay, capillary refill is less than 2 seconds. From here, we're gonna auscultate the chest. We will first auscultate for the 5 lobes. We are starting in on the patient's right side, starting at the right upper lung, right middle lung, right lower lung, and then we're gonna move into the left side for the left upper lung and left lower lung. We will do this both anteriorly, posteriorly as well. Afterwards, we will then use the ladder method, starting on the top of the clavicle and then moving down. Every time I place my stethoscope on the patient's chest, patient will breathe in and breathe out. 1, 2, 3, 4, 6, 8, 9, 10, 11, 12. Patient's lung sounds are normal bilaterally. We will then auscultate the patient's 5 cardiac landmarks, starting on the right, second intercostal space for the aortic, moving to the left for the second intercostal space for the pulmonic. Then we're going to be moving to the left, third intercostal space for the herbs, left fourth intercostal space for the tricuspid, and then left fifth intercostal space for the midclavicular for the mitral. Okay, from there we will then move down to the abdomen. For the abdomen, we're going to be inspecting for the condor is flat, abdomen is symmetrical, no signs of visible pulsation, petechiae or petechiae, however it's pronounced, any scars or stria, any visible masses or bulges. We can see that the umbilicus is midline, as well as the pigmentation and color of the abdomen matching patient's ethnic background. From there, we're going to move down to the genitalia. We'll be inspecting the skin, the tissue of the genitalia for health and color. We can see that the skin of the genitalia is clean, dry, and intact. Skin matches patient's ethnic background. There is no signs of lesions, breakage, or discharge. From this area, we will also assess urine and stool. Urine is straw yellow, clear, no odor. Stool is brown and formed. We will then move back up to the abdomen. We will first also to the abdomen. We will do 4 quadrants, starting at the right lower, right upper, left lower. We will be also continuing for 1 minute until we hear a bowel sound. We will do so on the right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. Bowel sounds are normal. And then afterwards, we will then palpate the abdomen. We will do the same thing, starting at the right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. We are looking for any, with light palpation, we are looking for any signs of tenderness, masses, or pulsations, which there's none. From here, we will then move up to the upper and lower extremities. We will have the patient get up their bed and stand. We will be assessing for patient's posture as well as their gait. We are looking for signs of tics, tremors, or spasticity. We have assessed that the patient's posture and gait are even and symmetrical. From there, we will then ask the patient, do you use any therapeutic devices? Patients state that they don't, which is good. From there, we will then have the patient perform the Romberg test. We will have the patient either stand wherever they can. They will have their feet together, hands on their sides. To collect base data, we will have the patient have their eyes open. We will be assessing for any signs of imbalance or anything like that. And we will do the same thing, but the patient will have their eyes closed. Patient reports negative for tests. They're well balanced in both with their eyes open and their eyes closed. We will then assess the upper and lower extremities. We will be looking for colorization. So the skin of the upper and lower extremities matches ethnic background. We can see that the skin is clean, dry, and intact. Hair distribution is even on both upper and lower extremities. We will then assess the condition of their nails as well as capillary refills. We can see that the nails of the hands are clean, no signs of cracks, as well as capillary refill being less than 2 seconds bilaterally. We will check the toenails. Toenails are clean, intact, no cracks, and we will be assessing for capillary refill less than 2 seconds bilaterally. We will then also palpate the upper and lower extremities as well as the tendons. No, that's not right. As well as the joints, as well as the joints. Palpate the extremities and joints. We will then move on. We will be assessing for shape, symmetry, tenderness, and edema. We can see that there's no signs of edema or tenderness. Shape and symmetry on both upper and lower extremities are normal and symmetrical. From then, we will have the patient performed. We will perform cessation tests on the patient with a Q-tip. We will have the patient tell us if they feel any dull sensations on their upper and lower extremities. Patient states that they do. We will then move on with the sharpness test. We will state to the patient if they feel any sharpness on both upper and lower extremities. They will relay back to us if they do. Okay. From there, we will have the patient perform a strength test with their upper and lower extremities. Patient will hold onto her hands and grip as hard as they can. Strength is symmetrical bilaterally. We would do so for the lower extremities. We will have the patient push against her hands on the soles of their feet like a gas pedal. Patient's strength is symmetrical bilaterally. We will also have the patient push against the force of our hands going up or down on both upper and lower extremities. Afterwards, we will have the patient perform range of motion exercises, but we will demonstrate starting with supination, pronation, flexion, extension, abduction, adduction, and circumduction. We will then state to the patient, I have completed my head-to-toe assessment on you. Do you need anything else before I go? No? Okay. Here is your call light. If you need anything, just let me know. I'll be back in a couple seconds. I have completed my final practicum.